For Dale and me, it's a tremendous pleasure and honor to welcome Dr. Des Schatz to deliver Endocrine Grand Rounds today. So I'll start by saying that Des, as you will learn for those of you who don't know him, was born and raised in South Africa. It's subtle, but you can pick it up in his accent. He's a fine person, a family man, great physician and scientist. He came to the University of Florida in 1983 to pursue his pediatric internship and residency, and then has stayed there ever since, rising through the ranks to his current position as interim chair of pediatrics. He's also the medical director of their Diabetes Institute and their director of their CRC. With regard to his scientific productivity, he's published over 380 manuscripts, is the principal investigator on several absolutely central projects in type 1 diabetes pathogenesis, including the TEDdy study. I'm very much looking forward to his talk today about personalized therapies for type 1 diabetes. Des, we're honored. The floor is yours.
David, thank you very much. Can you hear me speaking?
Yes, loud and clear.
Well, really, that was a very generous introduction, and I've always said really, hopefully nobody really comes to hear the introduction, but rather the speaker. You made analogies to two great people in Sydney Brenner, Nelson Mandela, and ironically, what we were talking about before, I actually am holding up here, is Nelson Mandela, and I quote him very frequently. I've studied Nelson Mandela significantly, and particularly in lieu of the conversation for today, this particular book, which I recommend to all of you, is Nelson Mandela's Notes to the Future and Words of Wisdom. So I really encourage all of you to read that. That certainly is a start for us moving forward as we hopefully have turned the corner, or do turn the corner, or attempt to turn the corner on COVID. But this is a topic that's very, very dear to me. And really, I think coming from David Harlan is very apt, because some of it may be controversial, because I think that there's been too much dogma, and I think it's time to really look at things and perhaps even turn the way we've done clinical trials upside down. So the title of my talk is Personalized Therapies for the Prevention of Type 1 Diabetes, Searching for Endotypes. And my objectives are really to define endotypes and the necessity to understand the heterogeneity of type 1 diabetes, to really discuss the important effect of age in the disease process, and then to describe current and future efforts aimed at interdicting type 1 diabetes. Let me also say to you that I'm also very happy should you decide to interrupt me at any time. You don't have to wait till afterwards. You could just say, hey, Des, clarify that, or I disagree with you on that. That would be perfectly fine too. So those are my objectives. And as I was sort of thinking about this particular talk, this is not something that's really unique to type 1 diabetes. I was just sort of thinking about where we were with COVID, and among the many discussions that I, faculty, family have had is, why some people get it, why some people don't, why some people respond, why some people don't. Is it the same for all? And clearly the answer is not. And yeah, just as honestly a spectrum of articles that come in from the Physicians Weekly, from the CDC, and from the Lancet. There is clearly tremendous heterogeneity in COVID-19, and really we need to understand so much more about that particular disease to really understand responsiveness as individuals and as a community. So why an endotype for type 1 diabetes? So let me again, for those of you who don't know, what is an endotype? An endotype is really a subtype defined by a distinct functional or pathobiological mechanism. So I want to again emphasize the word mechanism, because this is something that really, really I know the physicians and scientists at UMass have really spent their lives trying to understand. It's certainly something that in Gainesville, the University of Florida, we argue a lot about it. And we argue because we really don't know that much about the mechanism leading to type 1 diabetes. It's more than a phenotype, and a phenotype is just a characteristic or a trait, a morphology, a biochemical or physiological property, or a behavior without implication of mechanism. And really, if we fully understood the endotypes, that together with genetic and environmental influences will explain the clinical presentation, the epidemiology, and the response to different therapies. And again, we're still pretty much in the dark. We're trying to understand responders, non-responders, but we really, really don't know. And the hope is that if we really do define these endotypes, then we will be able to create what I would say is individualized or precision medicine treatments targeting distinct pathogenic pathways. So why do I say that? Here is a slide that I see. I see patients with type 1 diabetes. We say, well, you have type 1 diabetes. We'll see you in the in the clinic. And I want you to look at all the faces. There are young people. There are old people. There are some who develop diabetes at the age of 2. There are some people who develop diabetes at the age of 45 and even older than that. And I ask you, there's one face, but do you believe that type 1 diabetes is just one disease? Let me sort of go through just some clinical characteristics of a classical patient with adult type 1 diabetes, and this is a CGM from which I borrowed from Satish Garg, published in Diabetes Technology and Therapy. And really what you can see are blood glucose levels, and what you can see really are the excursions of blood glucose. And sort of when you sort of look at, let's say, the gray area, you can sort of see that there is a range between, let's say, 100 and 180. And there's not too much, yes, we see differences, but here's a classical CGM. You can see medians, you can see percentiles, but I want you to just look at this really to contrast this with pediatric CGM, where for any of you who've taken care of kids, we know how difficult it is to try and replicate what we see in adults. There's classically, high blood sugars overnight. We get them down, and then kids, adolescents, they eat, and then the 2-hour postprandial in the morning is almost impossible to normalize. We're getting better at it, but it's really so difficult. And what you see here in contrast are the tremendous variation in blood glucose between the kids and adults. And the next slide is perhaps a little provocative in my asking. Here are some data from the Type 1 Diabetes Exchange, which David and the UMass group were active participants in, and looks at hemoglobin A1C by age, and really looks and shows that the disease itself, the management thereof, is getting worse. And is it worse because they're adolescents? Here I'm a pediatric endocrinologist, and I understand puberty, or I thought I understood puberty until I had my own kids and realized that I knew so little about puberty. But really, is it the same disease that's occurring in kids versus adults? And yeah, we explain the very high blood glucose and the very high A1Cs that you're seeing in adolescence and early adulthood by the fact that it's just so hard to deal with puberty. There are so many issues. As a pubertal kid will tell you, any deviation from the norm is a cardinal sin, and to have diabetes on top of that only adds to it. But look at the A1C, and even in the exchange, which was really better centers, it's above 9, but between 16 and 22. And if we look at older patients, you know, the A1C comes down significantly to within the 7 to 7.5 range. And we know what the ADA and the ACE goals are, which is less than 7 and less than 6.5% respectively. But I ask you, is it the same disease? Now, where are we with type 1 diabetes? And I would say to you that the quest for a type 1 diabetes endotype and precision medicine lags. And we should admit that, not be too confident in what we sort of really do believe, but we really do lag. If we sort of think about cancer management in pediatric and adult patients, it's already enriched with personalization. And there is identification of disease-specific mutation and mutation-specific therapies. And we think about, leukemia in kids, and those with the Philadelphia chromosome and how they respond to Gleevec. And, they've done significant DNA sequencing, functional imaging, and integrative omic measurements. I think we're really, at the beginning for this. We've got a lot of data and we have not integrated the data. I know, see Sally Kent and on this Zoom, and I see Dale and David, and certainly in NPOD, one of the great challenges is going to be to integrate, the data so that we will be able to hopefully develop, if we have the right patients, specific endotypes. But the field of diabetes is much broader and less well defined. So when we just sort of think about where are we with classifying diabetes, the perception is there's type 1, type 2, but in reality, as we sort of go back and, as we sort of think about this even within NPOD, and we sort of think about some of the more recent articles, we're realizing that there's so much heterogeneity of the disease, from honestly type 1, which is 5 to 10%, and even within that, we have not been able to really define specific endotypes, to obviously the MODIs that are expanding all the times, to the Flatbush diabetes that we really frankly don't know how to classify. And then, as it's been described by others in the British group, of several kinds of type 2 diabetes, 2A through 2E, and that's expanding all the time, that perhaps specific therapies should be used, for those. I think we've had menus, but we haven't gotten to, again, specific therapies. So again, the need to prevent type 1 diabetes, I don't really need to, I think, tell you, other than to perhaps re-emphasize that there is over 1 million people, at least, with type 1. There's 1 in 300. We have about 20,000 new cases per year. The most rapid increase is in kids under the age of 5. The prevalence is expected to reach 5 million within the next 30 years. We know about the morbidity, the mortality, the inability to achieve control. And then, with some of the efforts that David and others are using, we're trying to reduce the economic burden through better and more integrated interventions. But we know that it's very expensive, and that the annual medical costs and lost incomes is in the billions of dollars. So where are we really? A couple of years ago, as part of the ADA address, I sort of put together what were the successes. And the successes were that, yeah, we can reduce complications, and we're now in this era of intensive management. We're on the route to closing the loop rather than our artificial pancreas. But we do realize, and we should really understand that insulin is not a cure. That we've come quite a way in our understanding of beta cell biology, which leads to replacement of beta cell function, which sets the stage for a cure, but there is no cure. And that we've understood that type 1 diabetes is a readily predictable immune-mediated disease occurring in genetically susceptible individuals, which sets the stage for prevention, but really there is no broad-scale, broad intervention at this point. So what is the road to curing type 1 diabetes? And this is what we think we know. Again, you're all very familiar with this diagram. It shows beta cell mass on the y-axis and then time on the x-axis. And we know that in order to prevent type 1 diabetes, we've got to ideally prevent the onset of autoimmunity. That would be a pre-stage 1, which I will get into, and stop the autoimmune attack if it's already there. If indeed the autoimmune attack is primary rather than secondary. And then also we need to preserve and replace beta cells once they're destroyed. But again, I think we also have to keep in mind that there is no cure without prevention if indeed it is an autoimmune disease, since the immune system has memory. So why have we had this limited success? Why have we had limited success in reversing type 1 diabetes? Well, despite the claims of so many around us, we know so little about the actual mechanism. I'm going to go through a little bit, what have we really learned from animal models? And I can already hear, chattering in the background. There's been limited success of immune interventions. And I would ask myself, is our approach wrong? Is this the wrong time? Is it the wrong combination? And again, type 1 diabetes is changing phase. And again, I'll spend more time on the heterogeneity of the disease, that children are not little adults. Well, is type 1 a primary autoimmune disease? I keep asking that question. And my colleagues, Mark Atkinson, Todd Brusco, and others don't really like me asking that question, because it's regarded that it's classically an autoimmune disease. But is it? We've asked this question. Is it a primary autoimmune disease? In other words, what's unique about the beta cell? Why the beta cell? Not the alpha cell, the delta cell, the pancreatic polypeptide cell, the homostatin cell? What is unique about the beta cell? And if we really do think that there's a defect, maybe the defect is there and then the immune system is secondary, which would go into, raise that question about suicide or the homicide. But really what I want to direct you to, and I don't know if you can see my arrow, is really, the bottom, because we know so little about this. Is this just a disorder of failed immunoregulation? But again, if it was just a disorder of failed immunoregulation, don't you think you would see more broad scale, immunoregulatory defects? But we think that the defect is unique. It's localized to the pancreas. I know in another talk I actually asked Sally Kent, whether what we saw in the pancreas was reflected in draining lymph nodes and in the periphery. But we think that this is a defect of immunoregulation, and we move from a state of tolerance with a greater balance of regulatory T cell function to autoimmunity, where we have more killing rather than immunoregulation. But is it? And I keep asking, is it? And I think we've got to keep on asking those questions. Is it? Because we really don't know. Well, what about the mouse? This is just, when I was talking to Mark, he updated the slide for me. He said that there are obviously many interventions that prevent type 1. Here's a whole list. There are over 700 now. And the question that I would ask is again, learning from the mouse, what I think there are very clear lessons, and I think that's certainly the subject of another talk. But again, we have to ask important questions, the relevancy of the model, we have learned so much, I do believe, but where are we now in terms of an intervention? You know, can we learn more from mouse models? Which gets to the next stage of a question that I said is, are we intervening at the right time? Well, this is, you've seen the slide, again, beta cell function on the y-axis, and on the x-axis is time. And we can divide the stages of type 1 diabetes into pre-stage 1, which would be a primary prevention, stage 1, which would be 2 or more antibodies, which is euglycemia, stage 2, which is 2 antibodies plus dysglycemia, and then stage 3, which is diabetes. But I again want you to sort of think about it as, this is not a slide, that a kid gets onto a slide at the top and then gets off at the bottom. That is really not what it's about. It's an autoimmune disease, so there are relapses and there are remissions. And who relapses and who remits, we really are not sure. And at exactly what time during this process we actually study them is very difficult. And that's why replication in the peripheral blood, which has been our almost only approach until recently, has been very difficult to find either consistent T-cell markers or markers of response, because we really don't know where in this process this is occurring, nor do we know whether those markers themselves are valid given the low frequency of responding cells within the peripheral blood. I mean, I just remember myself working in the lab and thinking, well, how many of these cells are responsive? And you know, you put it in a well and you get 1 in 300,000, 1 in 400,000, and you know, sometimes you get wells that have responding cells, and sometimes you get wells that don't have responding cells. So that does lead to some frustration, but again, keeps asking questions about, you know, the very essence of type 1 diabetes. Well, I ask about why we're doing new onset studies. Are we doing new onset studies? And it's something that I've actually argued within TrialNet, is this, and again, we could have a discussion about this itself. Are we doing it to preserve C-peptide? And for all the clinicians out there, they would say, of course, you preserve C-peptide. The DCCT showed that. And, you know, if we can do this, we should, you know, continue to preserve. But what I want to show you in this graph is that this is, and it's circled, the response. The response that you usually see to immunotherapy occurs within the first 6 to 12 months, and then the curves parallel each other. And the question is, what's going to happen at 5 years? Will they still parallel each other? We really haven't, you know, looked at them in detail. We now have some data from an initial study we had done with ATG, which would suggest that there are clearly responders and non-responders, certainly within that group long term. And that would also go with, by the way, with EDIC and its data and their data regarding you know, preservation of C-peptide. But we don't know if there's going to be a memory effect, as we're certainly seeing, or as we did see with EDIC. And you know, I'm going to show you perhaps some of the data which really are perhaps some of the most impressive in new onset patients. Study done in TrialNet, but really led by my colleague, and some of you know is Mike Haller, in which we used combinations of drugs. We used anti-thymocyte globulin plus GCSF because we thought the combination would be better, versus low-dose ATG alone versus a placebo. And in this 3-arm study, the most effective was ATG in preserving C-peptide. On the y-axis is the change from the baseline C-peptide, which is area under the curve C-peptide, and this is placebo. So clearly there was a difference because it was a 3-arm study. You know, and because of the way it was designed, and it was two-sided, 0.032 was not significant. But if it would just been an ATG GCSF versus placebo, there would have been significant. Well, did this have clinical relevance? The answer to that was yes, that if you looked at hemoglobin A1C versus ATG, G-CSF, and placebo, what you can see that is at 2 years, in the placebo group, the A1C was 8 on average, and in the ATG and ATG G-CSF, it was in the high 6s. So the preserved C-peptide also had an effect on reducing hemoglobin A1C. Well, how have we really done? So those are some of the most, if you will, successful studies that have been done. So it goes back to the question, why are we doing them? Well, obviously we really want to prevent or intervene in type 1 diabetes. So together with Mark and Amanda Poskai, we really put together a list of really looking at how many trials had been done really in the past 10 years. And it's not like we've been sitting around doing nothing. I mean, this field has really been working very hard, in this arena. And about 106 trials have either been completed or ongoing. And that number has grown, with a couple more that have been instituted. But these are, you can really break them down into antigen-specific and non-antigen-specific immune modulating trials. And I sort of want to show you, these are, and again, anybody who wants the slides, you can certainly have the slides. Antigen-specific trials in the past 10 years, which have really, we were hoping were going to be effective. We've used diapep, we used insulin, proinsulin, nasal insulin. We use DPT in the oral insulin. There are certainly subgroups. Really, frankly, all the effects that if we've ever seen have been in secondary analyses, which to me are nothing more than hypotheses generated. I mean, we did DPT-1, and then we looked to confirm the DPT-1 findings with oral insulin, and there was a subgroup that appeared to be effective, but overall in the groups there wasn't. And I think again that leads to a question: is should we be doing the studies that we're doing? And again, that's a debate in itself. So really, no significant effect of antigen-specific trials in the past 10 years. And here is a huge list of non-antigen-specific trials, and they range from really every part of the immune system that's been really targeted. If you go back to that original slide of mechanism, we get into the antigen presentation in the context of class 2 molecules to the CD4 T cell to CD8s directly to killing, to immunoregulation to killing, and really so many things have been done, honestly, from vaccination to modulation to regulation to immunosuppression. And really, in terms of prevention, there really hasn't been any really significant effect, perhaps until now. And here are some data, again, conducted within the TrialNet and led by Kevin Herold, in which teplizumab, which is an anti-CD3 antibody, was given to relatives at risk, for type 1 diabetes. And what you can see from this slide, again, is it's a survival curve, just as we see with cancer studies, that if you look at, let's say, on the y-axis, is none of the patients have developed diabetes, and then over time people get diabetes. There were 76 people in the group, and if you look at the teplizumab group compared to the placebo group, there was a delay in the onset of diabetes by about 2.5 years. So the time to type 1 diabetes was lengthened, suggesting that certainly in some cases, because it's not all, certainly in some cases, anti-CD3 monoclonal antibodies is effective in preventing type 1 diabetes. So what does this all mean? Well, for us as scientists, we've said, well, we've not failed. We've just found, as Thomas Edison said, about 10,000 ways that won't work. But again, that to me is honest, transparent science. Well, but the disease is changing. And I want to sort of show you how the disease is changing when we sort of look at type 1 diabetes incidence per year, and we look at really any of the countries. What we can see is a changing face of type 1 diabetes. If we just use Finland as an example, and we see that in Finland, really, in the early 60s, there were about 15 or 16 per 100,000, and now it's closer to 50 per 100,000, per year. So, it's almost like 1 in 125 Finnish kids of the age of 16 have type 1 diabetes. Well, what are we seeing? We're seeing increased numbers of kids. We're actually seeing decreased numbers with high-risk HLA alleles. According to data from the Exeter group, that 40% may be type 1 over the age of 40. And, some have called this LADA, type 1. From my perspective, they really are the same thing. You could argue with me, they're just different endotypes. I think the name is the same, but I think they're just different in adults compared to kids, which I'm going to show you a little bit more. But also, we're also seeing the effects of temporal patterns in type 1 diabetes, which clearly affect both presentation as well as response to therapy. And this looks at patterns of overweight and obesity. And if we look at how many in, again, the late 80s or the mid 80s when I trained were frankly obese, it was about, honestly, 4 or 5%. Now it's about 18%. And when we looked at overweight in the mid 80s, it was about 25%. And now it's closer to 70%, our patients. So really a change in the demographic, which must affect certainly response to therapy and perhaps affects the disease itself. So I do want to now spend the next few minutes talking about the fact that heterogeneity cannot be ignored, and that children are not small adults. And I'm going to go through quite quickly pre-type 1, post-diagnosis, the response to therapy, variation between individuals, within individuals, because that's going to impact diagnosis, personalized therapies, the varying etiopathogenesis and pathobiology, which really is systems biology, and therefore the need to define endotypes, which is going to impact all these things. So again, I already talked a little bit about this, that type 1 diabetes in the pre-type 1 phase is definitely heterogeneous. And again, why think of it any different to Crohn's or lupus or anything else? There's going to be relapse and there's going to be remission. And so we have to sort of think about that. And is there a trigger? And is there a trigger occurring at each age or not? Certainly, the TEDdy data has not shown certainly any specific trigger. And there may be some cases in which prolonged exposure to virus may be indicative of the subsequent autoimmunity. But really, there's not consistency, certainly within TEDdy, itself. Clearly, there's heterogeneity of pre-type 1 diabetes. And when you sort of look at beta cell function, and you can certainly look at the curves, and you look at what happens when you have islet autoantibodies and the development of diabetes, what a difference you see between early childhood, late childhood, adults, and LADA, if you want to call it LADA, which I still call type 1. Because here is a good example of something that was published 30 years ago, that if you were islet autoantibody positive in the first year or two of life, your risk of developing diabetes was 90%. But if in fact you developed type 1 diabetes, or let's say you developed autoantibodies in your 40s or 50s, that risk of developing diabetes over 10 years was only 10 to 20%. So I ask you, how can it be the same disease? Within TrialNet, we also saw the progression to type 1 diabetes. And again, what I want to show you again is a survival curve. And these were people who already had islet autoantibodies and had impaired glucose tolerance. And again, what you can see is progression to type 1 diabetes. That if you were over the age of 20, then the risk of developing diabetes, even with dysglycemia, was overall about 40%. And if you, however, were under the age of 20, it was closer to 90%. So again, age definitely modifies the rate of progression. So that again begs the question, are there age-related disease processes? And here are some data from the TEDdy group published by Jeff Krischer, and really looks at the age in which islet autoantibodies occurred. Now, you may recall that babies were screened for HLA really at birth, and the DR3/4s, DR4/4s, DR3/3s were followed, which was, in retrospect, we should have followed more controls. But be that as it may, we followed only the high-risk genotypes. And what you can see that there are clearly distinct groups. There is a group that develops IAA early, between 12 and 18 months, and then there's a fall-off over time. If you look at GAD, well, GAD starts coming up after about 18 to 24 months and then sort of remains positive. So there's clearly a difference, one that occurs early and one that occurs later. Are you IAA first or GAD first? And there's a distinct association with really IAA are associated with DR4. So if you have, as you can see here, again, his instance, this is DR3/4, you can see the early appearance of insulin autoantibodies in the DR4/4s, in the second one on the right, and the third one, the one at the bottom, there's DR4/8. But if you look at DR3/3, that is associated with the presence of GAD. So DR4 IAA, DR3 more GAD. I don't think it's as black and white as that, but it at least suggests or begs the question. In the pre-diabetic period, if the incidence of IAA as the first autoantibody continues to decline while the incidence of GAD shows an increasing trend, is this evidence of a different disease process? And does HLA determine disease process? And does this suggest additional genes or differences in etiology? So what I've shown you now is what happens pre-diabetes. Well, what happens post-diagnosis? Really the same thing. If you have a look and you look at the effects of age post-diagnosis, you can clearly see that if you're young, you start off with less C-peptide. So age is up to the age of 21 directly proportional to C-peptide. So it's a surrogate for age. But if you are certainly over the age of 21, if you can actually have a look at the curves, you can see that there are different rates in terms of the progression to certainly the loss of C-peptide. So that suggests, well, how can you lump all these patients together? And I would say to you, for us who've done traditional trials, you really can't. We should learn from it. And how can we learn? Now, you may recall that I showed you that one of the successful studies was ATG. Another successful studies was the rituximab study. And what you see is the same curves, that you see a response really occurring within the first 6 months, and then there is a decline over age. Well, you have to ask the question, in this particular group, what was the driver of response? And what you can actually see in this particular case, and again, if you look at the y-axis, and again, if you don't have enough time, you can look more closely at the slides. But again, the positive results are driven by children. that what you can actually see is that the control group not surprisingly, in the kids, which is shown here at the bottom, fell. But when you actually look at the group that were treated with rituximab under the age of 18, those were the group that was protected. There really wasn't much difference over the age of 18. Now, with the high dose ATG and Steve Gittleman's study that was certainly done, that showed potentially a more protective effect in adults. But again, let's just think about C-peptide and preservation and the variation with age. Here are data that was developed from the Type 1 Diabetes Exchange, and David's very familiar with this, and really looks at patients who are diagnosed under the age of 18, which is sort of shown in the orange, and those that were diagnosed over the age of 18, which is shown in the blue. And if you look at the one, let's say at the level of those who had had diabetes for 3 to 5 years, clearly far more people over the age of 18 retain C-peptide within the first 3 to 5 years. But again, a significant difference with those younger. Now, we also do know from work within NPOD and others, and within this, that there really is some C-peptide that occurs even after 40 years of diagnosis. And again, but again, it's again driven by age. Those that were diagnosed at an older age clearly have more C-peptide than those diagnosed at a younger age. This is a busy slide, but I do want to sort of show these are data from Martha Campbell Thompson and our group, and it shows pancreatic weight, which is shown here as in ABC. It shows beta cell mass, D, E, and F, and shows beta cell mass, beta cell area, should I say beta cell area here in D, E, and F, and beta cell mass in G, H, and I. And the point that I really just want to make is that overall, the pancreas is smaller. This has actually been now confirmed with MRI studies that the pancreas appears to be smaller in patients with diabetes. And again, what is sort of shown across the first column, if you will, are antibody negatives. And what you can again see that I want to bring out is tremendous heterogeneity. And then in B, E, and H is antibody positivity, and then those with insulitis. And the numbers are too small, but there's a little provocative finding that we haven't really gone through. But the point that I want to make is that there is tremendous heterogeneity in pancreatic weight, area, and mass, but overall the pancreas appears to be smaller. But I also want to ask you, is the disease the same as when I first started in the mid-80s? And here are some data from Danny Pipelier's and the Infeld and Martha Campbell Thompson, and looked at the islets in their series, which was published in 2011, which really gets islets from the the 90s and early 2000s, and looked at insulitis under the age of, within the first year. And what you can see from Peter Infeld in the group was that not everybody had insulitis. About 67% of those between the ages of 0 and 14 had insulitis, between 15 and 39, about 29%, about 51% overall. But nowadays, in the data from Martha Campbell Thompson and the group, that really there's insulitis. Not necessarily beta cells, but there's insulitis that occurs in the vast majority of cases of type 1, certainly within the first year. And that does decrease clearly with time, but there's certainly a difference between what Martha had published and what Peter Infeld had published. Now, the diversity has been well described, and beta cells may persist, as I said, over 50 years, and what I want to just to show is two medalists, but with completely different islet pictures. And these are just representative stains from Keenan and the group, that somebody, a 76-year-old who had diabetes for 56 years, still has, Ki67 insulin positive cells, and and even has some amyloid. And then another patient in which there is really no beta cells, and really what you see is a really glucagon. So again, asking the question, has everyone maybe was misdiagnosed, but is the disease process the same? And in the past we've lumped, and I really believe it's time to split. Well, here's even a really interesting slide, again from Martha Campbell-Thompson, and really looks at CD20 B cells, CD3 T cells, and also glucagon staining in this is also interesting, a 12-year-old African male with diabetes of about 1 year. The point that I really want to make is if you look, these are different islets, and what you can see is that some have staining, intense CD3 staining at the periphery. You also see some CD20 staining. But if you look at the 4 islets, I think that the only point that I really want to make is how different, the islets look, and which is the right islet, which is representative. So clearly not all the islets are affected at the same time, and is the process that's occurring consistent, meaning that perhaps we could stop it in some islets and get improvement, stop the process, because there are some islets or different stages of the disease that may or may not be impacted the same way. So what I think I've just shown you is that we have not been that successful to date, that children are not adults, that there is a difference in pre-type 1 diabetes. There certainly is a difference post-diagnosis, and there's also a big difference in the response to therapy. Now, all is not lost in the sense, yes, there's a difference between individuals and within individuals, but I think this gives us an opportunity for us to stand up, an opportunity to admit varying etiopathogenesis and pathobiology, because I think it's time to really integrate systems biology, and that systems biology may not necessarily be with big data across cohorts, but may even need to be done, at the individual level. And so we do realize that heterogeneity complicates the systems biology approach. So, as we sort of look at this, we always battle to find, some significance. And, we look at the genome, we look at gene expression, we look at the proteome, we look at the metabolome, and then, we say, well, that's clearly going to affect the immune system, or maybe the other way around, maybe the genome and the environment and the microbiome affects gene expression. So I think that is really what it's going to be, is that really this is if you believe in a biological system that integrates systems biology, that is a more holistic perspective. And, that is an approach that we could argue about versus a reductionistic approach, which certainly looks at, what we've done before is looking at one versus the other. I just think it's time to do perhaps both, is to really look at this, but perhaps looking at this at the individual level. and to perhaps provocatively state, and again, this will certainly open myself up to questions, but maybe it's time to look at the little boy with the circle and say, maybe it's time for some N=1 studies. Maybe it's time to sort of really understand what may happen in a particular individual, realizing that the traditional, clinical trialists who design studies, and I'm one of those, based on a p-value and a beta based on power, but looking at type 1 and type 2 errors. Maybe it's time to say, well, maybe we could do and at least look for responses in some people. Can we define who those people are and start doing, some of those kinds of studies? I think there's been a lot of resistance up until now, and will probably lead to an outcry by some of you, but I think it's time to start asking some more provocative questions. So I'm going to really end really where David began, which was to quote Nelson Mandela, that we all as a group, and I think that's what leadership is, we need to find solutions rather than spouting theory. Mandela said he was not an optimist, but a great believer in hope. I think we all have hope, certainly today. And for all of us who do type 1 diabetes research, it always seems impossible until it is done. And hopefully by I think that, and this is just not in any way to say this in any other fashion, but David Harlan has always been someone in my mind who's been prepared to stick his neck out. I remember him at the NIH, and I remember him questioning, prevailing dogma. So, and I learned, and I thought at the time that did take some courage, and he's never stepped back. So I say this both as respect for David Harlan, but also as a challenge to all of us, that I think that we're going to need to rewrite textbooks, that the prevailing dogma is not correct, that we're going to have to look at new ways of preventing and curing, type 1 diabetes. And I think, I've occupied the majority of the time. I'm happy to certainly open this up to questions. I would just say to you that none of us can do science in a vacuum. This is some of the people at the University of Florida, and I acknowledge the tremendous contributions of really Mark Atkinson, Mike Haller, Clive Possible, Todd Brusco, Clay Matthews, Martha Campbell Thompson, really Laura, really all the people who've really contributed, to an environment in which we ask these difficult questions. Unfortunately, we haven't been able to solve all the riddles yet, and also most importantly to the patients who've enabled us to enable us to hopefully put a few steps forward as we together, and really together with you at UMass, move forward towards making some significant contribution towards improving the quality of lives with patients with diabetes, which is the motto of the American Diabetes Association, or doing the research, which is so critical to both prevention and cure of this disease. So with that, I will end off and open that up to questions.
As that was beautiful and profound and inspiring and wonderful. I have just a couple comments, and for all of you on the phone, Des, we peaked at about 50 participants and people are going to peel off. So I want to let them ask questions first. I just want to say two things. Please wear your Kevlar vest to work each day and check your car for bombs underneath it before you drive, because you've challenged some dogmas. We all challenge them with you. It takes real courage, but as you know, that's the only way progress is going to be made. And then also, I promised to get you the check for saying those nice things about me. So let's open it up to questions. I have few, but I'll wait until others have had their opportunity.